Hello and welcome to my presentation today. My name is MarkWanklyn and I'm a senior medical physicist at Genesis Care Australia. I'm currently based in Sydney. As you can tell, I'm not Aussie. I haven't picked up the accent quite yet. I actually trained in the UK at Queen's Hospital Romford, and then I worked at Guy's and St Thomas's for a couple of years before finally making the move to Australia. Today I'm going to be talking to you about the implementation of a full end-to-end SRS service with VarianTruebeam and Align RT Advance. So just a brief look at the layout of my talk today. I'll start by providing a bit of an introduction to Genesis Care as a company, the setup that we have at GC Crow's Nest, which is where I'm based, how we actually go about commissioning just Align RT in general at GC, and then the SRS specific testing of Align RT that we've kind of come up with. We also have an interesting approach to commissioning SRS at GC, and then I'll go through the actual patient workflow of SRS simulation, planning using Varian HyperArc, and SRS delivery on a TrueBeam with Align RT Advance. I'll then just kind of finish off with a bit of staff experience and just a couple of concluding statements. So let's start with a bit about Genesis Care as a company. So as you can see from this timeline, so apologies for the kind of busy slide, but this is taken from corporate. GC is a relatively new company, only founded in 2004 in Brisbane by Dan Collins, who is our global CEO. And as you can see, kind of over the past 16 years, we have expanded quite rapidly. Not only in Australia, but also to all corners of the globe. So we currently have centres in Spain, the UK, and now the US, and we've got a foothold in China as well. There are currently over 30 centres, 30 new centres in development across the world, and I'm sure if the model's anything to go by, many more to come. So this slide kind of illustrates that GC as a company is a bit different than most cancer centers, which maybe have one or two sites. We have over 350 clinics around the world and over 200 radiotherapy treatment centers. Globally, we deliver over 4,000 treatments and we employ over 5,000 staff worldwide. We do also have a cardiology business as well, but primary focus is oncology. And we try as much as possible to behave as one department. So the idea that the vision of the company is that should you receive your treatment here in Australia, or there in London, or in Spain, or in the US or China, the idea is that you're receiving a high quality care. That's kind of the GC way. And this means standardizing treatments, techniques, equipment, and processes as much as possible. So now I'll talk about my little baby, GC Crow's Nest. We're a nice little department. Currently the only Varian centre in New South Wales. So New South Wales is the most populous state in Australia. It's also kind of where Sydney is, and we're based on the lower North Shore of Sydney at the Manor Hospital. So we're in the basement of the Manor Hospital. You can see there, right near enough to the Harbour Bridge and the Opera House. For those of you who have actually been to Sydney, so we're a 3-machine centre. So we have one TrueBeam with a Millennium head, upgraded to version 2.7. We have a Halcyon 2.0. We have one extra superficial machine and a CT. We are an Eclipse and ARIA environment. However, we do have Mosaic integration as well to ensure consistency across the board in the company. We have Align RT Advance on our TrueBeam. We are yet to upgrade our Halcyon to inbore. We have 2 physicists based on site, myself and my colleague Tina, and we treat roughly 60 patients per day. And kind of how we work is we have kind of site, state, national and international project procedures and techniques. So at the MADA, we were actually, GC Crow's Nest, apologies, we were the first site in GC Australia to implement Align RT. Our go live was in May 2019. And the system is used in some capacity for the majority of patients, either for passive monitoring, gating, or breath hold. And Align RT has allowed us to introduce tattoo-less treatments. On the right-hand side there, you can see an excerpt from Channel 7 News here in Australia, where we were kind of highlighted as offering this new tattoo-free radiation treatment to our patients, for all our breast patients, as well as our prostate SBRT patients. Alongside our colleagues in the UK, we've developed a national framework for commissioning training of staff and treatment. And we recently became the first site in GC Australia to upgrade to the latest version of Align RT, and that's Align RT Advanced. However, subsequent sites have followed on from the work that we did. And I'll briefly talk about how we approach the commissioning of Align RT, kind of in the absence of an international report or guidelines that we had here. So the first few commissioning tests are your standard, I guess, peripheral equipment tests. So integration of that equipment with your record and verify system, with your planning system, and also with your Linux accelerator. So basic functionalities of beam hold functionality, patient matching and things like that. We also localized the field of view, and this was actually determining the extent of the Align RT field of view in terms of couch positions, and also at which gantry angles it's likely that at which gantry angles does one or both the Align RT cameras get blocked, therefore increasing noise in the signal. We also tested spatial reproducibility and drift, and that is over time, and also how stable how stable does the system believe that it can be. And we've also determined non-complainant tracking accuracy as well. So that's including couch rotations. A couple of other tests that we did was static localization accuracy, and that's moving essentially a phantom to a known position. And then we also used the SIRS dynamic platform that can be seen on the right-hand side there with a static phantom on it, to track spatial accuracy and actual dynamic radiation delivery for gating. So SRS-specific Align RT testing. So these are some tests that any of our centers which would like to have SRS with Align RT should perform. So to begin with, we use the Align RT cube. We set up the cube at ISO using a KV CVCT. We then obtained a reference capture to zero out the deltas. The couch was then rotated to 0, 45, 90, and 315 and 270, with an MV image taken at each new couch rotation to see if essentially any couch walkout had occurred, and if any shift would be required. So this is obviously just an MV planar image. And the idea is that you're not checking, I guess, couch walkout in a sense, so you're just checking that if there is any couch walkout, that Align RT system has picked it up as well. And this was, as I mentioned, repeated in multiple couch angles. So you can see it from the right-hand side there, the two graphs showing on the top the translational errors between Align RT and MV planar imaging, and also the rotational ones as well. So you can't, due to the fact that it's MV planar, it's not possible to determine any vertical kind of shift. So, but also Align RT didn't detect any vertical shift either, so therefore it's zero at all couch angles. Laterally, there is very little movement and very little difference in the positioning, in the, I guess, positioning error picked up by Align RT and the MV planar imaging. It's actually in the longitudinal direction where the largest differences are seen, and it's at the more extreme couch angles, 90 and 270 on the Varian Linux. Rotationally, accuracy within 0.1 of a degree or agreement within 0.1 of a degree. So that's pretty good. We then repeated this and used an anthropomorphic head phantom in the full patient immobilization setup that we would use. As we mentioned, setup at ISO using KV-CBCT, the deltas were zeroed out, and again it's a couch rotated and compared with an MV image taken at each new couch rotation. And you can see quite similar positioning, well, quite similar results on the graphs on the right-hand side. Vertically, it was actually possible. Well, change was noticed mainly in the Align-RT system. Again, it's a planar image, but Align-RT detects change. However, this is within 0.1 of a centimeter, and also in rotationally well within a degree for all 3 degrees of freedom. So now I'll just talk about kind of how we go about commissioning cranial SRS. So this isn't Align-RT specific, but I thought I'd just touch upon it. So we have a set of national commissioning tests. These are 12 set cases, each testing a specific aspect of SRS delivery. And this can be different dose per fraction, different PTV sizes. This can be single PTV, multi-mets. It can be off-axis distances and things like that. So cases 1A to C are different lesions on central axis down to 0.8 centimeter PTV size. Cases 2A and 2B are different size lesions, 3 centimeters off-axis. 3A and 3B are different size lesions up to 6 centimeters off-axis. 5A and 5B are single met, 5 met single ISO cases at different dose levels, so each met either receiving 6 or 20 gray. Similarly, case 6A is a 10 met case, but again at 2 different dose levels. And case 8C is a full end-to-end testing in the Steve Phantom, and this they're all measured with ion chamber and EVT3 film. So you can see just on the right-hand side there a nice kind of difference, a film plot of one of the multi-met cases and the ion chamber results at the top. So SRS simulation and patient immobilization. So what do we use? We want to use HyperArc, the variant HyperArc solution for multi-met cranial SRS cases and also for single beds. So for this, we actually use the Encompass mobilization device. We don't have the full Encompass overlay. We actually only have the S-frame attachment cradle, and that's what we use. We also use dual faceless masks for Align-RT monitoring. As you all know, Align-RT requires some skin to be monitored, so the cut-out faceless masks are great. We also use this in conjunction with a mouth bite, which obviously isn't shown on a Phantom. As per kind of Align-RT guidelines, we ensure that the eyebrows and the upper lip are exposed when creating the mask, and we want the face aperture to come down as far as possible down the side of the patient's face as possible. This gives us the largest surface area to monitor when the patient is on the bed and in the mask. And the lasers are aligned to the markers on the Encompass cradle. So how do we actually go about planning using HyperArc? For those of you who may not know what HyperArc is, it's a class solution for treating single ISO multi-met cases. At GC, we have the HyperArc planning license, but not all centers have the HyperArc treatment license due to costs. So at the Mano, we don't actually have the delivery license, the treatment delivery license. However, we do have the planning license. Therefore, we can make use of HyperArc planning and kind of all the tricks that come with it, including the Aldo algorithm to minimize kind of the bridging between METs, which is highlighted quite nicely on the image on the right-hand side there, and also the dry run feature, which allows for kind of patient collisions and things to be predetermined. We calc our plans using Accuros XB, and we actually report dose to medium, not dose to water anymore. Once the HyperArc plan is generated, There is an option to remove automation, so which is the which is the high product delivery in the room, whereby there is no intervention required by the treatment team, but we actually remove that because we actually kind of want that ability to intervene. So how actually it gets delivered on the TrueBeam using a line RT. So the patient's set up as normal, using a line RT to get patients in a rough starting position with pitch roll rotation and translations as close to planned. And this is actually before they get their mask put on. Then once the patient's in a suitable position, we put the mask on and we again check and make sure that the patient is comfortable within the mask. And we actually ask the patient to have their eyes closed during the treatment, and this is just because kind of any blinking or eye movements can actually throw off the line RT system. And when the patient is comfortable, we obviously leave the room and capture a KV-CBCT and perform an image match as per normal. This tends to be a bony match, or if you can actually see the met that you're treating, then it'll be matching to that. And we apply a reference capture once any KV-CBCT shifts have been applied. And this is to zero out the deltas of before. We actually have the 3D photo available in a line RT Advance, which, speaking to the therapist, makes ROI delineation very easy. So we don't actually want to include any mask or any kind of immobilization equipment in our monitoring ROI. So actually having that 3D photo makes it so clear to make sure that the mask, the eyes, and everything aren't included. And then we switch beam control on, so that it's actually gating should the patient move at any point during the treatment. And as I mentioned, the delivery is not automated. So the therapists themselves must go into the room each time to rotate the couch and make sure, and they actually use a line RT to get the patient into position. The MV image is taken at each cap rotation, kind of similarly how we did with those commissioning tests, at each new cap rotation to verify the position. If the patient is not in a suitably planned position, we have a nice workflow for that. Then we rotate back to zero, perform another cone beam, and check that the patient actually hasn't moved. As we mentioned, beam control gates the beam if the patient moves outside the tolerance, and for SRS treatments we use 1 millimeter and 1 degree tolerance. So the first patient that we had was I think he was 5 METs, and he was on the bed for around 23 minutes for the whole treatment. So really, really good. Just a bit about our staff experience at the Mater. In short, they love it. We've been really happy with our SRS program since it went live. We did used to have an SRS program prior a few years ago on an old single energy machine, and patients would be on the bed routinely, kind of for upwards of an hour at least. That machine got replaced with the Halcyon, therefore we've moved our SRS program onto the TrueBeam. And as I mentioned, in general, treatment times have come down for patients that we treat with line RT. So this isn't just cranial patients, this is every patient that we currently treat. So that includes our breast DIBH patients, it includes our pelvis patients, and actually, as we tend to use a line RT in some capacity for most patients, everyone's kind of benefited from that. And as I mentioned, we were able to treat a multi-met patient in around 30 minutes, where on our old machine it used to regularly take upwards of an hour. Setup time has been reduced, and we've introduced tattoo-less treatments for patients, which has been a massive selling point for kind of our program at the Mater, and we've had a lot of patients come through due to the fact that they no longer have to have those tattoos. And DIBH processes are much easier as well. We used to have the snorkel system, the ABC system, and now it's less invasive for the patient. There's, especially in the current situation that we are with COVID, a lot of less risk for the patient, whereby we're not having to put in anything or getting close contact with the patient or anything like that. And just on the right hand side there is myself with my colleagues, therapist Nikki on the right hand side and Tat on the left, who helped us out with the commissioning. So just finish off the presentation now. Align-IT, as I said, can be easily used to complement SRS treatments. SRS specific testing capabilities include couch rotational accuracies, full end-to-end patient testing, including patient immobilization, and imaging coincidence testing that we've done. I mentioned it's great for positioning patients in the mask prior to setup imaging, so you're having to actually, it's possible to reduce repeat imaging for the patient. And as I mentioned, with Align-IT Advanced, the staff really love the new interface, and actually especially the 3D photo module. So thank you very much for listening to my presentation today. So thank you very much and have a nice day.